Good morning and welcome to our monthly live broadcast of endovascular peripheral arterial intervention cases from here, Mount Sinai, New York City. I'm your moderator for the day, Vishal Kapoor. And another exciting case in this toasty New York City summer. We plan to have a little bit of change in flavor. So instead of going lower extremity, we're going to try something poking around in the upper extremity. So a very interesting case here by Dr. Krishnan and his team. Talking about tips, tricks, complexity, treatment options, and further management. So without further ado, good morning, PK.
Well, thank you so much, Vishal. So welcome to our cath lab. As you know, we're here, in a hot summer day here, but really talking about a case that I think is very, very practical for interventional cardiologists, which is a brachiocephalic disease. And it's actually a very, very complex case. So I'd like to thank David for bringing this case to us all the way from Queens. But our team today is a little abbreviated, as Dr. Raman Sharma and we're missing Dr. Raman Sharma and Dr. Karthik Guja, but we're joined here as always by our vascular surgeon, Dr. Ajit Rao, who's kind enough to add his expertise and give of his time so all of us can learn. That's to David's right. To my right is David Song, who's the assistant director of the cath lab here of the endovascular division. And then we've got Ray Lascano behind me, and we've got Shalini Mani. So without further ado, I want to introduce our nurses. We've got Denisa and Risa, and we've got the amazing Damien here to help us with all the equipment that we need. I'd also like to thank our AV team for always being ready to help us, set up these cases. So without further ado, Shalini, would you go ahead and present?
Yes, absolutely. Good morning, everyone. Our patient today is an 87-year-old female who presented to us with a history of intermittent episodes of dizziness and lightheadedness over the past 6-7 months. She also noticed a significant difference in blood pressure measurements between the right and the left arm. The left arm BP being consistently lower than the left arm, which is around like 35 millimeters of mercury. She denies history of falls, syncope, collapse, chest pain, or palpitations. Her past medical history is notable for hypertension and hyperlipidemia. Her current medications include a statin, aspirin, and an osteoporotic medication. Moving on with the evaluation, her baseline blood works, everything, CBC, basic metabolic panel, everything was pretty much normal, and the ultrasound duplex of upper extremity was showing a complete flow reversal in the left vertebral artery, consistent with subclavian steel phenomenon. One can see on the picture, which is shown in the right side of the slide, the left subclavian artery could not be visualized in the arterial duplex. And moving ahead to the CTA head and neck in both sagittal and axial planes, showing the aortic arch. The origin of innominate and left common carotid or grossly patent with scattered atherosclerosis, and there is severe atherosclerosis with significant calcification at the proximal left subclavian artery, causing a near complete occlusion with distal reconstitution. So this is her CT image. And this is her still image of non-selective arch iotogram showing the significant stenosis with severe calcification. With this brief clinical summary, I'll let PK to take over with further discussion.
I'm going to just ask, obviously, Jit, when we called you, David and I, we wanted to show you this case. Obviously, there's a lot of choices, carotid subclavian bypass versus intervention. So in this case, it's very particular that you really need to know what, do the right thing if we're in the wrong plane here. So what are your thoughts on an endovascular approach for this thing versus just a direct bypass? That definitely was a clear option as well.
Yeah, I think that's always something to consider is what your all your endo and open options are. Okay. So I think for open surgery, obviously, it would require general anesthesia. It would be more invasive, and for the most typical way we fix this is through a carotid subclavian bypass. And for that, you have to look at the carotid. So number one, you want to make sure the carotid's healthy because that's going to be your kind of inflow to the bypass. In this case, I think it is. But then I think for her, kind of, she's elderly. I think she's in her 80s, if I remember. So she wouldn't be a great surgical candidate. So if this can be fixed endovascular, which it looks like there's a channel, and especially with some new therapies, which we'll talk about, I think it's doable. I think trying an endo first approach in this case makes sense.
Yeah, so we have a very low threshold to stop, so this might be one of the first ones we failed in our live case thing that we've done. But I think decision making is very, very important, and I want to talk a little bit about what we did. So we got left radial access, and then we got groin access. And we put a 7 French pinnacles 90 centimeter sheath in the groin. The arch, as you saw by the aortogram, is very, very calcified, but also very narrow. So it's very difficult to engage from below, which might be ideal, but we thought we could cross from above. I'm doing this sort of a dry cine to show you the level of calcium. You can see there's a heavy, heavy calcium chunk there. But surprisingly here, you can see here, this is the tortuosity of the subclavian, the vert, which we're going to talk a little bit about now. And this is the injection from above, showing that there is some flow. You'll see above and below,
right.
But there is a little bit of flow. You see that? But again, it's not a very convincing picture. So you can see here, there is some sort of like, I guess, what is it called? Bridging collaterals, if you want to call it, or something. The idea would be to engage it that from below, maybe easier to cross, which I'm going to give a good attempt. But I thought we can try from above. So Ajit, can you talk a little bit about the vert? What are the things that they need to know about the vert, and what we should be doing in these kind of cases?
Yeah, for sure. And that's something, also to mention when you're deciding between endovascular versus open, is if you don't have a good endpoint, so obviously, endpoints are the most important when you're putting in covered stents. So if your lesion goes past the vertebral, then it's probably not a good endovascular candidate because you'd have to, stent across the vertebral and you could, cover it and lose it. In terms of the vertebral, only in an emergency setting have I ever kind of sacrificed it, but really you never want to do that. But things you have to consider are what the other vertebral is, if that's open,
100 centimeter
what the dominant vertebral is, and then whether the circle of Willis is intact. That's probably one of the most important, because if you don't have an intact circle of Willis, then they will definitely, become symptomatic, and you can cause a posterior cerebral stroke. So, but in general, I think it's just good practice to always be mindful of the vertebral and try to protect it.
Yeah, and I think for everybody on the audience, I'm going to switch out from 45 centimeter because I'm going to go with a no torque here, guys. I'm going to go with a no torque because I think it's the right catheter. So we'll just wait for the 45.
Yeah, I think it's a great point that Ajit brought up, which I think we really underestimate in education, especially like PK talked about treating these subclavian diseases, is the role of vertebral. The whole idea that the patient is symptomatic, dizziness, lightheadedness is probably suggestive of posterior basilar circulation compromise with steal phenomena happening to the vertebral. So most likely, like Ajit talked about, asserting and determining whether the vertebral is dominant on the side of the intervention, not dominant, as well as the circle of Willis will be a major factor in determining the course of the treatment, meaning the approach of the treatments. In this case, most likely the left-sided vertebral is the dominant, where you're having some steal phenomenon, and that is causing your symptoms to happen. So it's very important that we preserve the vertebral in this case in order to help with what we're doing with the patients per se. So a very important certain topics to consider for people who don't do this often, just to be cognizant of the fact of the entire circulation per se.
No problem. So what I'm doing here, I mean, Ajit and I talked about this. We flush that 90 centimeter and keep it ready.
Yes.
What we're going to do is we're going to go with 100 centimeter, 45 centimeter here. Go ahead, push it all the way up. And then what we're going to do is we're going to try to cross from above and below. From below, the arch is a kind of, for lack of the better word, pain in the you-know-what, all the way up. And so what I want to do is go ahead and have a 100 centimeter vertebral, no torque, which I think would really engage better this catheter. So I'm gonna go ahead and walk the dilator out. Give me the no torque, guys. Yep. So our ACT, Ajit, we're at 300. When was the last ACT, ladies?
So
15 minutes ago.
So you tried initially from the top, PK, with what?
We haven't tried it yet. We've just got a vertip catheter engaging the thing. I mean, once I get this up there, Ajit is going to try from above. I'll try from below, and we'll see who we cross. The idea is to snare, and then go, and then we'll see what happens. Let's just see if I can let the wire go, guys.
So
see
what's
if I
your
can let the
wire
wire go.
strategy?
Wire
What's
go.
the thought process? What do you do with your wire strategy in these cases? What's your algorithm, so to
it's
say,
gonna
or
be
your
too violent
experience
again.
in using wires? What do you
It's
start
not
with?
gonna work. Yeah, look at this arch. This arch is a
Yeah.
painful arch, man. I'm telling you. See, nah, I don't think it works.
The problem is a very small arch, like the aorta itself is so small, so it doesn't give you that much.
I don't know, maybe. Give me a
Flexibility
little dye here,
there.
guys. Let's see what happens here. I'm going to inject a little dye here. Coronary, guys? You're on
I
coronary.
mean, I think in this case, I would probably opt for 014 first, because the channel is so small and calcified. But, sometimes you just don't get the pushability, to really do it. And
the other thing we could do, Ajit, is go with a carotid VTEC or something, but it'll be too aggressive, I think. That's the problem.
Yeah, I don't...
The calcium is more distally, or you have to go,
I mean, I think in this case, the other thing that we talked about before was just like arch type. So this one definitely has a little bit of a, it's definitely, I wouldn't say a type 1, but at the same time, I don't think you need a huge curve here to really engage the subclavian.
Give me a JR4, guys.
So I wouldn't do anything like a reverse catheter.
No, this is not it.
It's too much curve on it.
What's going on?
Yeah, so I think you almost need like a hockey stick sort of catheter to really engage it.
Right there, that's just a touch.
Yeah, but I need to push it and then torque it. It's not going to be easy.
So I think if you push your catheter a little bit, it should pop into that push.
You're a very positive thinker.
If it was healthy.
There, almost. Yeah, so now.
Let's see if we can wire it, maybe? No. Oh, no, I'm in aortic plaque there.
But yeah, I would say 014, but then ultimately, the stents, you need 035, so you do have to switch out at some point.
Yeah.
And so sometimes, the glide wire will just fly through, especially if there's a good channel. But I think in this case, there's a lot of there's a lot of plaque and calcium, so I'm not sure what's going to track, to be honest.
Nah.
No, that's true. You're right. Especially the CT showing that there is some micro channel, so to say. So it's almost subtotal. So you're right. Starting with an 014.
It's not subtotal. It's total. Trust
total.
me.
So yeah, it is total. Sorry, clinically, and it is total.
Why is she
trying
moving?
to find a micro channel through a 014 probably give you a little bit better, hopefully, outcome than rather than go with the
I'm just going to try to wire it through this. What are the other the command?
Right.
What are the other wires we have? I mean, what are the other catheters we have? We have the no torque. What else do we have?
IM.
IM's not going to work. No. What JB? JB maybe 2. JR may work. Let's try JR.
I think JR should be a better option with less curve on it.
Yeah, less curve. There it is.
There it is.
Nah, not quite. Yeah, give me a JR. All right.
Just the JR.
In the meantime, I'm going to have a JIT try from above.
Yeah, I was going to say, maybe channels on the top might give you a little bit more.
Yep.
So here's...
Glide wire? Or?
Yeah, well, whatever wire you want. Let me give you a little
try
dye from above here for them to see.
Let me try a glide wire. Very carefully.
Glide wire?
There you go. Ready? Just so everybody at home can see here, that's our
the
vert right there, the lever right there.
Calcified. Wow.
Yeah.
You have a little bit of beak. Yeah, you're just, like I said, I just try to poke and see if you can.
This is JR? No.
Connect the dot.
Yep.
Give it, Dr. Rao, a 014 command wire, Rajit. What do you want?
Yeah, I'll start with command, and then if not, glide wire.
Command.
Another one.
Yeah.
JR4 catheter, guys?
Or V14 is also good.
Actually, yeah, we don't have V14 here.
V8.
We have
Or
V8.
you can try those CTO wires of 014 before you go glide as well. Like you say, you have a channel on one side, or a beak, I guess, not a channel, but a beak on one side. So hopefully, an 014 stiffer like your Astaros or other wires can give you a little bit more support, and then try to cross.
Yeah, for sure.
Rail, guys? Pull the wire back a little. I don't want it near the coronary. Pull it back. Pull the wire back.
Well, you're right. I think PK is absolutely right. The arch itself is, even though it sounds type 1, it's pretty much acting like a functional hostile arch. So it's not giving him any flexibility to start do from below. But hopefully if you can cross up from top, might give you some more leverage. But, oh, there it is.
No, I think we tried that before, but
okay. It's behaving.
It doesn't look, unless it's hitting there.
Yeah.
If it bounces off that, it'll be wonderful, but it looks like it's dissecting.
Yeah. I wouldn't want to force that.
No, I agree. Not the catheter. Maybe.
I mean, we could try snaring it, and then we would know.
Or maybe the catheter. You know how if you flip the catheter, if it touches the wire?
Yeah.
The catheter is right there.
Yeah, but it's not.
It's not, so that means you're right. See?
Yeah, I just don't want to advance the catheter, make the channel bigger.
Not this. I'm taking the catheter from below, from the groin.
and then I want to get a curve on this
like
thing.
PK is trying to, you know how we do in AAA, you just flip the catheter.
Yeah.
Yeah, it's not touching, so you're right. It's probably subintimal. Otherwise, this catheter from the groin would have moved the wire.
Yeah, we have a very low threshold here
Yeah.
of moving to surgery, honestly.
Maybe this looks...
no, same problem.
I'll try it with a curve.
We can try with a snare through
Yeah, but
this.
you always want to think about
Give us a snare.
the things you can do wrong. Every case,
No, of course.
so like we talked about the vertebral, but the other end you can create a dissection, if you're really aggressive. So
The other thing is a tour guide, but I think the arch is too small for a tour guide, Ajit.
Yeah.
yeah, I think it's going to be a lot of manipulation, which obviously in these cases you want to minimize.
Yeah, I agree.
I just don't know how it's going to act, to be honest, but.
I think like PK's
I think it's either from
best
above
bet
or
is to-
bust.
Yeah,
I think,
was gonna
yeah,
say,
above
best
I
is
bet
think
the way
is
it's
to
from
from the
above or
top.
bust. Yep. Because I don't want to keep manipulating the arch from below. So we'll try from above here, both of us.
Yep.
Give us what other wires would you guys choose? You want to get a snare ready from below so we can try to... Yeah, give them a snare from below. We'll put a snare up.
Yep.
Maybe we interact, maybe we don't.
Yeah. Can I get an 035 wire from below?
Yeah, I think you need a...
No, I just want to see whether I can find another channel because I just found that channel. The idea is if we can find another channel, it might be nice. There it is. That's another channel right there.
Yeah. Do you want a different catheter,
And I
maybe?
just want to try to advance this a little bit into that channel. Hold it there, Ray.
I'm gonna pull this wire.
What wire do you have, PK, there?
Just a command.
Oh, okay.
Nope, same problem as a jet. It likes that little...
There, that looks... no, just popped out.
That may be a little better here. Let's take a picture, Ray, here. Let's let a jet go with the snare, and then we'll try.
Okay.
So again, like Dr. Rao was saying, you don't want to create a... This is on coronary, right, guys?
Yes.
Yeah.
So what I'm doing is using the calcium to kind of guide me. So here, you know that the calcium... Hold it right there, Ray. Let's see if that pops.
I mean, I like it on the medial side like you have. I think it'll give you more favorability, but that small
pull back
dissection
again.
plane.
Can I get the snare catheter?
We can try a stiffer wire, like a weighted wire.
Oh. What's the
Yeah, I
length of
agree.
this? What's
Because
the
then
length
we
on
keep
this
going
snare?
with the command, will technically keep going through.
Can we get a longer one?
Yep, I agree.
Maybe take an Ostaro or any of your
All right, let me try.
Yeah.
wires to the liking.
Give us a 014 Ashtato 20. Or else the worst comes to worst is poke with a glide.
Yeah,
Yep.
I think that's the last thing.
Got wire.
In this case, maybe even a more aggressive, like a 30 or 40 over 8 might
Okay.
give you a little bit more body to break through
Okay,
that
alright.
calcium and try to find a different lumen.
Yeah,
Since you already have an 035 catheter there, you could use the over 8 Ostaros.
Look up wire, please.
But you're right. I think everybody has to realize that a lot of people do subclavians and it sounds very
Ostato?
easy, bada bing,
Look at
bada
that
bang.
calcium.
Yeah.
But in this case,
wire forward,
it's
maybe,
very
Bob?
important. You have to be careful, very
Wow.
cognizant of the fact of where the wire
part
is,
of the
the
wire, pull the wire
feel, the
back.
tactile feedback.
No, it's
Everything
not
is
gonna go.
important
Not
to
gonna go, right?
attain a desirable result.
Wow.
So I think what PK is doing is not being aggressive, trying to find the channel, using the wires, escalation, going from minimal to a higher weighted, I think is the right approach.
Ashtato, guys?
That's where it is
Ashtato
very
did.
important just to consider we don't end up in like what Ajit was talking about, the various complications that could happen. So going slow and slowly upgrading a wire is very important in these kinds of cases, and using a calcium as a marker is the benefit right there. So
Give me a curve maker. There you go.
There we go.
Now we're just going to lay that out, and that'll be
Let's see.
our target. Let's see.
Big target.
Huge
I was going to
target.
say,
Find a channel. Big target. Well, I think this is you obviously want to pick a big snare for this, so I can't remember the exact number, but it's at least 15, 20, something like
it
that.
looks like a 20,
So-
but it must be 15,
Yeah,
20. Yeah.
to at least get most of the lumen of the aorta.
Yeah.
Not easy.
No.
Like, we try to do realistic cases, right, that are really tough. This is definitely realistic. Tarka guys here? No, that's not it. Nope. That's definitely not it. We know that.
Mhm.
Nope. Torque it the other way. Hold it there, Ray. Let's see. No, that's not the way we want to go. No, don't push. Now? I like the kind of moving now, brother.
Yeah, I know.
Yeah.
That's what I'm saying. It moves freely, but you're right.
I'm not sure I can reduce this. No, let's see. Don't have it, but if I can.
It looks too. Yeah.
You think I'm in the thoracic cavity? At least if we move it, then I'll be happy.
Right.
Yeah. I think just an interaction with it will be the best.
Right. That's what I was looking. Just see if it even hits
yeah, if
the
it
wire.
touches it. Yeah, exactly. That's what we're talking about.
Just having a hard time getting it into the
Arch.
with all that calcium. We couldn't get the catheter to track through that calcium. But I'm staying distal to all the great vessels. That's why I'm being a little more aggressive.
Yeah.
You want to pull the wire back a little bit and then see if I... Advance it a little more. Let's see.
Maybe you want to come AP, maybe just change your view a little bit, just to give you a little bit more
That's
perspective.
exactly what I was going to do. No, it looks like we're not in the right lumen.
Yeah, this angle, it's harder to tell because it actually overlaps.
No, I was just trying to get a perspective of where it is. Okay, so at least it's...
No?
No.
Oh. It's stuck somewhere now.
No, it'll come back.
You know, it kind of looks...
I know, I was going to say...
You want to do I kind of like the LAO angle better because you can kind of see the aorta.
Yeah, you don't know where they're running parallel.
Give me a glide wire now. Actually, you know what? Give me the Terumo 018 wire.
What about like using an angled like a catheter or something just to help you? Like
you want to go with like a Lima catheter?
Yeah, something that can give you a little more angle to really
Lima catheter
try to poke into different channels.
Up top, and give me a woolly wire first. A woolly wire, guys. So we're going to change the catheter up top for everybody at home.
Find the direction.
Yeah, and then go with a Lima. That's fine.
Yeah, I think you're right.
Woolly
just
wire.
Going a little bit in the center or even
Or you can give me a super core, whatever you have.
Is the 1.8 to remove?
Yep. So see the challenges. You can't even get the snare across the aorta. So this is a really, really challenging case.
Yeah.
Yeah.
If you look at the CAT scan, I mean that, it's like pretty much severe calcium, nearly occlusive, and so that's what makes it really challenging, because trying to poke through that calcium is almost impossible. But if we did cross it, I mean, obviously, I think, we all agree on shockwave, right? To kind of pre-treat this lesion with all that calcium.
Yeah, we should talk a little bit about goals of therapy, right? If you do cross it, crossing is the real challenge here, and that's what we're trying to do online, but let's go LAO again.
Yeah.
Oh, we are LAO. Okay, sorry. The idea would be, okay, if we are fortunate enough to cross this, what's the story in terms of what we're going to do?
Yeah.
Got a little more, Richard.
Okay.
So we are 30 minutes into it. We have not even budged it. So let's see how it goes.
Yeah, it's a very challenging case right there with the calcification and the arch, but hopefully, with PK skills and some optimism and Ajit's pushing, we'll be there.
We'll be there. Let's see.
Well, to the other point, there's no reason to be aggressive, right? Like
Exactly.
you have an option of
exactly,
bypass.
and that's a very important thing for everybody at home. There is absolutely no reason to be aggressive because you do have a surgical option, and that's part of the reason you need to work together as a team. And then when you work together as a team, you do what's right for the patient and what's best for the patient. Okay, so so now we're in a different plane now. So let me have you want to go with the glide, Ajit?
Yeah, I think let's try
Let's
glide.
go with the glide, because I don't think we're going to work with anything else.
think we just need a lot of support in this case.
Mm-hmm. Actually, give me the 018. Let me just play with that for a little bit.
I was going to say, yeah.
The Terumo. Let's try the Terumo 018 first, the gold tip, and then for a few little bit, just to see what luck we have, because sometimes this will plop right into the true lumen when we're doing this.
I think the wires having a tendency to go into the medial side of the plane, you see.
We can do V18 next. I mean, V18, the problem is the steerability is not much, right?
Yeah.
I mean, there you go. See, that went somewhere. Terumo always finds a way to go somewhere. Say that's. I don't know if we're there. Let me see. Just found a way somewhere, but it's not really. They can't torque it.
Through the calcium, it looks like.
Yeah, looks like it always finds a channel of some sort.
That looks.
But there's no way that snare can go to the. Yeah.
I mean, I can try a stiffer wire. We can.
There it goes. I mean, can that be a dissection? I don't know.
Usually, no. Oh, there. It's
just really nice for it to go into the ascending or descending, you know?
Yeah.
Just so we can confirm.
Pressure is a little low. Budget.
Should we get a pigtail into the aorta and take a picture?
Take an aortogram, guys.
Okay.
Okay, give one neo, guys. She's bradying.
Let me get a glide wire.
Let's give one neo. Oh, everything's okay.
Mm-hmm.
Okay, give one neo.
Stiff glide. Just get some good imagery.
So everybody at home, she started bradying a little bit when I was doing that stuff. So we're just going to make sure there's no perforation or anything. So we're going to go with the pigtail into the aorta. So let's see. Okay, one neo. All right. Again, that's one of the reasons you want to hemodynamically monitor. Yep, monitor them. Okay, walk it out. Okay, she's coming back. Okay. Because we didn't do much manipulation from below, so I'm not worried about from below. I'm just worried about above.
Okay.
Okay, pigtail. Oh, this is a glide wire?
Yeah.
Okay. Yeah, okay. So maybe a little bit of something.
It might be just transit. I don't know.
Yeah, but you just want to make sure. Let's give 0.6 of Atorvastatin. Oh, no, she's okay. She's bradying because of the neo. So,
okay. Got one.
Can we talk to her, guys? How's she doing?
Let go of wire, please.
Hold it there. Can somebody talk to her, see how she's doing?
Okay. Full strength in a syringe.
Yeah, I think the blood pressure now is stable, yeah.
Yeah, blood pressure is okay.
You ready?
Yeah, but that's, again, a very important point that was
fine.
brought
We got
up.
a power injector.
Wait, we got to set this up.
Just to be careful, make sure everything is in place, the patient is safe, and there's no perforation if there is, to identify it early on. So I think important to look at the hemodynamics as well. So a good point to reconsider, especially in these complex cases.
Yeah. Go to low mag here.
Yep. She can take a breath hold. That would help.
We need a breath hold DSA, guys?
Yeah.
Okay, ma'am, take a deep breath in. Let it all the way out. Okay, let it out. Don't breathe, don't breathe, don't breathe. Don't breathe. Don't breathe.
Yeah, looks fine.
Breathe normal. Okay, that's fine. Okay, so we can keep going here. So let me come down. Above it looks good too. Okay. Okay, breathe normal.
But you can see how angulated that aorta is, which is
look at
part of the
subclavian.
Yeah. And no real channel in that.
Give me a vert tip now. I mean, a woolly wire again from up top. So is she okay, Risa? Everything is okay? Her arm felt heavy, so she was vagueling a little bit. Yep. Okay. So again, guys, I know that it was a little, I'm quick to call the trigger. The reason is, again, this is an elective case. It's an endo case. It's not a life-threatening disease here, although it's very lifestyle limiting for her. But there are other options. So you always want to err on the side of doing careful work in anything that you do. So that's part of the reason why I said, okay, let's stop there. Let's take a picture of the aorta and see what happens. This wire just wants to go there, huh? It's a nice. There it is. That's even better. I like this spot a little better, Jit, because it's right in the center,
different,
isn't it?
Might poke through.
Give me a mag it up and give me a coronary view here. Put it on coronary.
The other thing we were talking about a little bit was the steerable sheath, which
Yeah.
I don't know if it would help us or hurt us.
That's what I'm worried about too. I'm
Yeah,
on coronary.
the markers are right on top of her.
I think that's
but I
pretty
think
good.
I like the. Yeah, I think it's a good channel.
Different
Just running
channel.
parallel to the
Yeah.
calcium.
Mm-hmm.
And that pigtail kind of gives you a good landmark of where the aorta is.
I think this is the good magnet to show it's all calcified. The arch, the reason PK is having so much difficulty torquing and everything is look at the degree of calcification.
You hold it there, right?
It's a true
give me
Subclavian disease right there.
014 wire.
That's
give me
what's
that
causing all the issues.
Terumo wire.
Give us a new.
No, the Terumo wire, the 018, the M.
The Terumo Gold. Yeah.
Okay. So guys, it should go into that aorta. Can you play the aortogram for them in this view so we can show them the flow of the aorta so they understand which way the wire should also go? The wrong end. She's giving me the wrong end, guys. You see that? So it should go down and
Give
up.
us a new gold. Give us a new gold.
What happened to this? Look at the tip. That's not the right tip.
Take a new one, yeah. But I think in this case, you're right. The wire will have a tendency of going down into the ascending aorta. So
Right. So you definitely want to be able to be careful here with that. So, so the idea would be, even if it goes into the ascending aorta, that's fine. But the point is, if you need to guarantee that you're in the aorta.
Correct.
And I think that's the trepidation that Ajit and I are having because we're not 100% sure that we're there. So it's, very easy to say, oh, let's push, let's see what happens.
No.
But your bailouts are very limited. Because of the calcium and because of the fact that it's very hard to get a seal if you're not crossed. So, am I on coronary, guys?
No, that's the old. Yeah, this is the new side. Oh, no.
And then I guess the other thing to mention, the vertebral, but also like if the patient has a lima, of course, that's another consideration.
No, I'm still in the calcium there. No. Torquer, guys. One last attempt here, and then we'll go with the 014. So.
Yeah, I'll probably go a little bit mid to lateral like you were doing initially, and that gave you a better plane.
But the wires just seems to want to go here.
Yeah.
It's so interesting that the wire is so ridiculous that we have absolutely no torqueability here on this wire.
So I think since you have a GR, if you want to try an Ostaro 30, 40 or a Confiance towards more mid to lateral segment and try to dig it in, hopefully you'll find a newer plane and then you can put your glide wire into that newer plane and then hopefully try to pop through it.
Yeah, but see, we are pointing medially, but look what happens when we come. See, it pops out laterally. So that seems to be the prevalent channel. Ideally, I think crossing this from below would actually be easier. You like that?
It did for a second.
How's that? But it's not moving, see?
Maybe
see?
Where does it go? But see, that kind of looks like
It looks like it's an aortic plaque, though. It looks
hard
like
to
I'm
say.
dissecting the plaque above, right?
Can you spin it down a little bit and just...
Not really.
No. This is spiraling around it.
That looks good. That looks really good, actually. If it goes further, I think...
Can you flip the pigtail to see if there's any interaction?
Okay.
No, right? Yeah.
No, it's staying on the wall.
It feels as if it looks like it's in the wall.
The last thing I want to do is to create a retrograde dissection.
Right.
So, there's a lot of issues here, guys, that we got to watch out for. Right now, that looks like it's getting into the plaque and creating a retrograde dissection. So you really have to be careful, So what do you think, glide wire or no? Final attempt?
Glide wire.
Glide wire. One attempt and done. So get ready, gang. We may be done very shortly, saying goodbye to you. Ajit will get a carotid subclavian for this wonderful lady if David decides to clear her. Oh my goodness, I'm telling you.
So the only other things, would you want to try from a steerable sheath? Just see if it helps.
We could.
Just briefly, it's either going to line up well or it's not going to line up.
We could. Open the tour guide, guys. Let's try the tour guide one last time. I mean, we can go with Confianza, but the point is, I think, we could try the Confianza.
Yeah, I would probably do an Ostaro 30 or a 40. It'll give you enough support.
All right, give me an Ostaro 30 first before we go with this.
Yeah, I would. And then you can do your glide wire if you like.
I agree. Let's try an Ostaro 30 and then we'll go.
It's conservative enough, but still will give you enough body to try to poke through it. And I think you're right. It's just that calcification channel, and if you poke through it, the wire fly.
But I
But it's
really
hard.
believe that, see, what's happening is you don't want to create a retrograde dissection.
I agree.
So, you know, the idea is not to do a retrograde dissection here, you know? So
Study 30.
you just really want to be careful here not to create that retrograde. Like Ajit and I saw that aortic plaque, we were getting under it and we were very uncomfortable pushing that forward.
But that's why I agree with you to not to take any catheters across. Just feel with the wire, see how it does. If we don't like it, the wire comes back and hopefully we are good. Yeah, you're absolutely right. Once we start crossing or tracking a catheter into it, then we are in bigger trouble. So maybe just wire crossing and getting a feel should be at least still be relatively safer rather than going with the catheter itself. So you have your catheter support right there. So you should be okay. So I think just giving it a curve and going a little bit more into the center or laterally will give you that channel.
The other problem is like all these osteo lesions, you just can't really cross from the other way, you know? You just don't have any like purchase with your sheath.
Mm-hmm.
So it's really crossing retrograde a lot of times.
This is like a double whammy.
It's like a iliac, you know?
Yeah.
See, I'm not comfortable with that, Ajit. Are you?
Not really, unless it like flies down and feels okay.
Yeah, I think it's about the feel.
Now it's moving. I don't know what that means to us.
It's a different plane, but I don't know. The peak.
The other important thing you're doing is you're not advancing the catheter. You know,
correct,
you're not
that's what
propagating
I said.
the.
If you don't advance the catheter, then you're still on the.
Nope. Pigtail definitely is not interacting.
Yeah, it's a big loop. Does it go easily further down or no?
I'm afraid to push it any further.
No, just the wire. Yeah.
I mean, that looks pretty good, to be honest.
Yeah.
Give it a little dye in the pigtail, a little injection in the pigtail, see what a little dye. Just a little dye. Just test. Looks pretty good there.
That looks promising. We can try to get a snare.
Can you flip the pigtail, Piki? Just spin it like you do in your AAA? No, it won't. I know. I'm just, listen, I know it's easier sitting from here and saying, yeah.
Well, it's like what Ajit said, right? You don't want to manipulate this arch too much either.
Yeah.
I know,
but to me, this looks pretty good.
The
other thing we could do is IVUS it.
You want to put an IVUS through that? You okay with that?
No, I mean from below.
Oh, you want to put an IVUS from below and see if you see it?
Yeah, see it in the lumen.
Okay.
But the other thing is we could just get a snare there and just see if we can capture it.
Let's try a snare.
Let's just do the snare.
Let's do a snare.
But that's the other.
I mean, the IVUS, the issue will be
you would need an
035 IVUS to really visualize that aorta because of the reach of the IVUS. So I don't know if you want to put a 9 French system in there to do an 035 or an 8 to do an 035 IVUS. That's the problem. 018 is not going to show you much with that aorta right there.
True. Yeah. You'd have to upsize the sheath.
Yeah, you upsize to at least an 8.
It's a different view here. It's so hard to tell, guys.
This wire looks like it's in a completely different plane and it's going super easy.
Yeah, it is.
So I'm hopeful.
All right, let's see if the snare goes.
The snare was catching some plaques. That's the only other problem.
Yeah, you're right. Maybe a little bit smaller. I don't know. Smaller.
Where's that?
What size snare do we have?
I think you're okay. I'm just going to...
15?
We have a large snare, yeah.
We have a large snare. That looks like it.
Okay. All right.
Snare catheter?
Snare catheter.
You always pick tough cases, PK.
Well, we have to, right? We got to show them the cases that that's the reality of what we do. Okay, check in ECT, somebody.
Wow.
This is the problem we were having before.
Maybe try to take the snare down from here.
There you go. No. There you go. Okay, you're good. You're good.
Okay, good. Oh, goodness, careful.
So it's true that calcium right at the origin of the subclavian is what's hindering everything, including your engagement from below as well as passing all these devices.
So I guess this, in my opinion, guys, if this doesn't go, we'll manipulate for a few more, and then I think we call it a day. I don't want to take a chance. Like I said, we have an option. Mm-hmm. We have a surgical option. We have a great surgical system here. So I think we just do that.
Can you get the torque on then, please?
Mm-hmm.
I'm just going to be careful here since we're near the arch vessels.
Yeah.
Can you advance that wire?
You want to advance a wire?
Yeah, sure.
Just the wire, and then yeah.
Mm-hmm. But I don't think we're in it. It didn't catch it. No. I think I have to pull the wire back and maybe...
Yeah. Try that?
No, we're outside of it. That's obvious. There you go. That may be better.
Okay. Yep.
Nope.
Oof. Wow. So yeah.
I just don't know whether we're in the right area.
Yeah, exactly.
Yeah.
But
It looks like it, but remember, we could be on top of it. We could be in dissecting in plaque. We could be doing any number of things.
It just flies so freely now, but I agree with you.
yeah, I mean, you could be in the wall because it's actually going along the ascending aorta. So either we are in the lumen, like you said, or just.
I could pull the snare back a little bit. It's just
No, we're not in the right spot.
Okay.
Show me above, guys.
I'm just gonna pull this back then.
No, definitely not.
Oh yeah.
All right, I think the glide wire and outage it. What do you think? You want to try? Yeah, give it a whirl. You do a lot of aortic work. You can do a whirl.
Can I get a torque, please?
Yep, the torque is right here.
I see what you're saying.
You know what I mean? It just doesn't.
It has a
feel right.
little resistance to it. Which...
Just doesn't feel right. You'll feel like you're gliding along that plaque. You know?
Yeah.
Maybe that I like that angle a little bit. No, not that angle. Maybe there you go. Come on. Now see you're on that plaque again. See that? It digs into that plaque, that aortic plaque.
Yeah, and it doesn't go past that, so I don't want to force it.
I agree. That's why I was being very careful. That's a better angle. Come on, baby. Yeah.
Yeah, that calcification is really a big hindrance right there.
See, it almost fooled you. Let's get the tour guide. You want to try it from below?
This
Here,
felt
Well,
better.
this maybe a little bit. Come on. Such a
No.
tease, huh?
Well,
You got it? You got it?
No.
All right. You want to get the tour guide and try?
Yeah, let's try the
All right,
tour
let's try
guide.
the tour guide. Pull that back, Ray. The
This
catheter.
feels so good,
No,
though.
so
right
pull
here.
it back. No, so I think it might be just on the side of the snare. So
All right.
can you pull back your wire just a little bit and then try to rewire it into it?
Oh, actually. Okay. See if you maybe see that.
Mm-hmm.
Might be just behind the loop of the snare. See? Because this, yeah. See, now it's going in both directions.
See if I can pull it back, and if we get it in the descending, it'd be much more favorable.
Yeah. See the way it flips, right? Yeah. See,
I just I said it just. I mean, again, I don't want to take any chances.
You're right. You don't. Sometimes you can get fooled.
We got it.
I got it.
Nice job.
Okay.
All right. I'm going to feed the wire. That's great. That's what we want to do here. So let's feed the wire slowly.
Okay. Yep.
Hold on. Let me just. Okay, you pull, and I'm
gonna
feeding the wire.
Gently pull.
There you go. Pull. So now we're in the descending. Can you track, guys? Hold on.
Yeah, you definitely have to feed it to me because.
Yeah, I'm just feeding slowly.
Yep.
Ready?
Because the other thing you don't want to do is shear the subclavian, if you have a lot of tension on the system.
Okay, hold on.
Yeah, let me just catch up. Oh.
Okay, hold on. Stop. Come up, please.
Yeah.
Show me above. I just want to watch the subclavian and my catheter. Okay, go. Go.
Yeah, there's plenty of slack right now.
Slow. A lot of resistance on my end.
Oh, really? Okay.
Look, you can see when I'm pushing here, a lot of resistance.
Yeah, sure.
You want to push a catheter through now from above?
Once you have the wire out.
Yeah, let me get the wire out.
Yeah.
If it's too much resistance, let me know, but it feels fine from my end, so...
Why don't you push from here? It's coming.
You'll realize.
Trust me.
No, I think you're right. Going through the lumen and everything, it probably is giving you a lot of resistance.
Almost there. Hey, mosquito, please. There, that's good.
Okay, now we're through and through, guys. So we got through and through. So now we need to... So what I would do is now...
So
we can...
Should we pre-dilate from above and then switch to...
Well, I'd like to take a picture, and the issue...
Or does that catheter go through?
The catheter will go through, but the question is, before I do that, I want to look at how we crossed. So this is very important, gang.
Yeah.
How did we cross this lesion? Did we cross central-luminally? Did we cross, across the one of the walls? So it looks like we're not true central-luminal. You see that? Play that again, David. You see that, guys? So when you see this lesion, a minus, yeah, you play it now. So you'll see how I'm on the side of the wall. We're side of the wall now. So you have to understand that obviously that's going to be an issue. But what we can do is we can change this out for a 018, Navicross. We can change it out for a Navicross, which is less traumatic. Give me an 035 Navicross, guys.
Yeah, I guess the question is how are we going to treat? So if we're using shockwave, we have to stick with the
014 balloon, 014 wire,
Yeah.
yeah. But I thought if we get the Navicross across, you'll reduce the resistance to pull the wire, and then we can work with, we can
like a grand slam or
work with the
something.
Grand Slam.
Okay. So
I guess the biggest question is you have to have a sheath from below, right? Before you start doing everything from below?
We have a 90. We have a 45 centimeter sheath right now.
Okay, great.
But the question is, we needed a 90, but we pulled it out because we didn't have enough purchase for
Right.
the snare. So now, again, all the challenges of what we're talking about. One thing we can do is change this to an 035 wire through the Navicross, put a 90 centimeter sheath up, and then treat.
I think that might be the way to go.
Smart
'Cause
thing.
just have everything ready, you
Yeah.
know?
All right, get a
Everything
90
ready,
centimeter sheath ready, guys. What's the length on my shockwave balloon? Okay, that's plenty. Okay. No, I need a short one, not a 6-0. All right, to the nurses, I'm going to go through the CTO now into the aorta. Always let the nurses know, guys, what you're doing. Look at that.
Give you a little. I don't want to give you too much tension, but I'll give you a little.
Okay, now we're essentially through the aorta. So, okay, follow it.
Let me
guys.
control both wires, please.
Okay, rail both, please.
Yep.
Rail both.
Yeah.
Okay, now I'm in the sheath. I'd like to externalize out of the sheath.
I think you'll just reach the hub right there, yeah.
Show me down, it's not going any further.
Yeah, we can always
We're right there. You can just put a wire through, right?
yeah.
All right, so
And then-
off with this wire. You're going to pull it out that way.
Yep.
Up, pull. Should be no resistance.
Yep, very little.
Okay, give us the super core now.
Yeah,
And
so
then,
just for the audience, what PK is trying to do is
Might have
just
to pull the
increase his
valve out
sheath
and then,
length so
just
that
put
way
a
he
cheat
has
or something.
accessibility directly to the
No, for the super core,
subclavian.
we can go right in.
So
We
that
wire
way he can do all the interventions from below rather than doing from above. So what you do is just put a microcatheter down and just married one into the other,
we just do this.
and now exchange the
Oh,
sheath
I
to a
see.
longer length sheath, which he was talking about, and then work from
And you can torque that.
below. So,
Let's see.
But
Flora?
Uh-huh.
Right next to your leg.
but I
Maybe
think
you might need a glide wire here. Torque that just a little bit. There you go. There you go.
nice.
You holding it?
I got it. Oh,
Yeah, you gotta
for
hold it
tension.
there.
Yeah. But again, I think. Oh, okay, 1
Yeah,
second.
you gotta pull it back.
oh no.
Oh,
What is
hold it.
there we
There you
go.
go.
Wow.
Yeah.
You're still in the catheter, right?
I think it's just
He shows the arm.
soft to stiff transition with that
There you
arch.
go. Okay,
yeah.
we're through. Show me down the arm now. Arm, guys. No, don't pull that out yet.
Yep.
Now show me the aorta now. Show the aorta. Forget the arm right now.
Yeah. And now it's going to...
Yeah, now it looks good.
Okay, good. Okay.
I'm sure it's outside. I just
Okay, pull it out.
yeah, I feel it here.
Pull it out. Oh, I got it this end. Just pull. Watch the pressure now, guys.
Okay, got wire.
Good. Now, attach that.
Just okay.
90 centimeter sheath now. I'm going to walk this out. We're not going to have enough length, but we just push it straight.
Great.
Ready? Go ahead.
Yep. Okay.
All right, get me now another, flush the Navicross and get me a, I'm gonna need a, what is it called, Spartacore now to take this
Spartacore.
through.
Right.
Laura? Okay, dilator.
Take it out.
Do you have enough
those
length of
things
the
just-
wires from both ends?
Like just pushing it up
Yeah.
without the dilator to engage.
Okay.
There you go, now I'm engaged.
Right
Okay,
there.
I'm gonna take the dilator out.
Yeah. Now put the Navicross through.
Nice.
All right, cycle a cuff, ladies. I want the cuff going while we're doing this work.
035 Navicross?
Yeah, he's having the navigation.
Okay. So what are you thinking? You're thinking
I'm
about
going to
switching?
put the Spartacore
It's
through,
flushed
nail it
already.
outside, then push this
The
up, take a
shockwave.
picture, and then do shockwave.
Spartacore here.
Okay, ready?
PK, you want to hook up your sheet to your pressure?
Yes, yeah, we're doing that right now. Bro, can I have the pressure, please, for the sheet? Flush forward, guys.
Yeah.
Flush forward for me. Flush.
No. Sorry. Hold on.
Flush again. Flush. Don't worry, I got it. I'll do it the right way. Okay, good.
We don't have wire
Flora.
here, but
Yep, Flora. Should be no problem. You're going to stiff part of the wire. When the wire comes, let us know. Wire.
Why is that?
perfect.
Yeah.
Okay, and go through the lesion. Yep,
All the way up.
went pretty easy.
Keep going. I want it to come out here, and then we're going to feed. Keep going. You're good. Keep going. I've got.
I'm hubbed right here.
You're hooked.
Yep.
Yeah.
So then we're going to have
Photo
to.
shockwave.
Pull the wire back and use the Spartacore.
Shockwave.
No, that's not-
So I guess we're not going to have through and through. It should be okay, right?
It would be nice to have through and through, but
Well, let me feed the wire to you. Hold on.
Yep.
Hold on. Pull the wire. Pull the wire. Now go through it. Now see if you have enough to go. Keep going.
it's a sheath, yeah.
Oh, you're already there. Okay. I don't. we're gonna
Yeah, I
have through
don't.
and through.
Yeah.
Yeah, I think it's the
Unless
sheet
you
is
want to,
gonna-
unless you want to wire like I did into the radial sheath with a cheater. Let's try it.
I think we
Let's
can try it without, and then we'll just leave it in the wire, and we
Right.
can always snare it from above.
Take it from here.
Okay, I'm pulling the wire out.
All right, guys. Spartacore now. So make a C loop on the Spartacore, please. So there's another thing for everybody at home. You want to make
Where's
this pigtail
the,
loop on this. I got it here. You want to make this pigtail loop on the Spartacore so it doesn't cause any perforations in the arm as you're working, because you literally just don't want to create any issues. So Ray is making fun of me because I can't. Actually, Rowan is making fun of me because I can't see. But so anyway, so I got a pigtail loop now.
Yep.
Now I'm just going to put it in here. Can you show me the arm, David?
Yep.
So I want to show everybody how the loop creates. So this way there's no issues.
Yeah.
So
I
you
think
can
that's-
see here, see the wire, the catheter is all the way down, pretty far. I think he had resistance. There you go.
It might be. No, not.
It's just
Yeah,
probably
you're
It's
right
in
at
the
heart.
sheath.
You're actually
Yeah,
in
yeah.
the sheath.
Yeah.
That's why it's
So-
giving you resistance, because it's hitting
So
the
that's
sheet.
fine. We can always grab it later.
Yep.
So we're going to walk this one out now.
That's even more protected in that sheath.
Right. So at least we can always grab it with
Yeah.
forceps if we have to. All right. So now what I'm going to do is after this whole thing comes out, we're going to do
Ibis?
a picture. And pull.
I'm out of wire.
Just
here.
pull.
Okay.
Good,
Got wire.
Flora. There you go. Because the
Okay.
resistance of the subclavian is not going to allow it to go.
Right.
So now we're just going to take a picture here, guys, through our sheath. Sheath is too low. God damn it. Hold on.
Not sure it's gonna.
Not gonna. No. We'll put a side by side 035 wire. Gonna get a
Supercore.
035 Supercore. So the problem, as you see with Shockwave, we have all these challenges because we have to go
Right.
we have to go with the 014 system. You know, so it is an issue. But obviously, for the trackability of the Shockwave and the deliverability of the Shockwave, that was very important. So what Ajit and I are going to do here is just put an 035 wire to give us a little more support, and then kind of track both the lumen and that up to there using the fire. Now I'm going to have Ajit pull out the 035 wire with leaving the 014 in place.
Yep.
I got it. Okay, now we're going to do a picture, guys, coronary. She's not going to stop breathing. Ready? Inject. Okay, there it is. Okay, now let's just do a DSA.
You want to do a little more LAO?
Yeah, a little more LAO.
You could see a little bit of more antegrade flow.
Okay.
Okay.
Okay, ma'am, hold your breath. Hold your breath. Huh? Okay.
All right.
Nice.
Okay.
Open business.
So here we go.
What do you think? An IVUS shockwave or
Ibis.
I think we're an IVUS it.
Yep.
Let's get an IVUS, guys.
IVUS for
Yeah.
sizing and everything, and then I think we talked about this too, but we're going to be conservative with the sizing and how much pressure we go,
Yeah.
because we don't need to create a perfect channel. Just relieve the pressure gradient is really the goal.
Exactly. So let's check an ACT right now.
Yeah, I think.
Do you
that's
think? I mean, the other good point is to know if we're subintimal, right? Is that the other reason you're doing the IVUS?
Yes, 100%. But since we're doing
Size.
it's more for sizing, in my opinion.
Yeah.
We have the CT, but I think if we go ahead and do it this way, at least we're understanding how. We know it's heavily calcified. We also know whether the IVUS passes or not. It should, but this IVUS can be pretty trucky. As you can see, there it is. So okay, so now there we are. All right, ready for can you ring down? Can you put the IVUS up for Dr. Kapoor and the team at home?
We can see. Just can you adjust the image? Go to 55, maybe.
55 image, please.
Yeah,
Okay. There you go.
Yeah, much better.
Much better. All right, record.
Good.
Record.
Okay, pulling, and you can see here we're coming back, and so we're still there. There's, okay.
That might be the vert.
That's the vert right there.
Yeah.
There's a lot of grunge there.
There's
Looks like we're luminal, huh? Right?
It's hard.
It's hard to tell, but
Hard
looks
to
like
tell,
we are.
but it looks like that tiny
Well, you
channel
can-
we're trying to go to.
Yeah.
Yeah, I mean, you can try the chroma flow mode and see if that helps you. But yeah, it's it's very significant. Like you said, it is 100% CTO occlusion, so it's very hard to say in this place. But yeah,
Yeah.
with
All
the
right,
calcium
shockwave balloon,
saddle
40
right there.
balloon,
But
please. So it's an 8.0 by IVUS. 7.0
Yeah.
is fine.
Yeah, 7.
40 is fine.
40 is only 80. I have 16. 6 or 16 is 135.
yeah,
You
I would
don't have-
probably go a 6.0 just to give me that
That's-
enough.
The distal end of it was like closer to 6, so we could use either, probably.
Yeah.
All right. You have
Just
a
again,
40?
like BK said, being conservative, cracking that calcium.
All right, 60 is fine.
I know we talk about 1-to-1
60.
always,
Yeah.
especially in shockwave, but in this case, I guess one step down would not do no harm kind of thing.
Well, let's talk bailouts here. What are we going to do? God forbid, anything is possible. The idea here is obviously you don't, I think worst case scenario is rupturing into the aorta or the aortic ostium. So you have to be very, very careful because you have very heavy plaque there. And the idea here is it's a gradient-based decision that you're making. So gradient-based decisions are going to be made, you don't necessarily have to take this, 100 millimeter gradient to 0. So what you really need to do is just go ahead and reduce the gradient, and the patient will have terrific relief of symptoms.
Yeah.
So, the second thing is we've got arm access. So if we ever need to put a balloon in, we can. We've got a 7 French sheet from below. We can put a balloon up. Again, we've got all the coverage stents that we need. Not that they are going to be 100% fail-proof, but at least they may buy us some time. But this is something where conservative therapy, I think, group-based decision-making is the right way to do it.
Yeah. And I think
So what
another...
size shockwave? Sorry, go ahead.
No, go ahead. I was just going to say, I think another nice thing about doing the shockwave is you can see how it opens up,
Yeah.
It kind of gives you kind of an indication if your covered stent's going to open up. If you see you get some good luminal gain with this.
Well, I'm very curious to see if the shockwave.
If it doesn't open up, then it will be another discussion about what to
see
do.
if the shockwave is going to cross.
Yeah.
What size shockwave do we take
6.0,
finally?
6.0 rate,
yeah.
positive in the sheet, brother.
I think that's a good decision.
Well, we might be hanging it a little bit in the aorta. We'll see.
Which is okay, yeah.
Is it there? No, we're just
Not yet.
Yeah, I think it's just the sheath has a tendency of coming right there. That. Wow. Oof. Oh my lord.
This is where through and through arm. Oh, there we go.
I think that's good enough.
Yeah, you're definitely past it.
I'm going to just pull my sheet back a little, and we're just going to go up here. Slowly, remember, again, guys, the lot of dangers here. You see you got the aortic plaque. I just want you to show you the aortic plaque. You see you have the aortic plaque there. So what I'm going to try to do is just pull the sheet. Hold on, don't go up. I'm going to try to pull the sheet down. No, it's not going to change the. So what I don't want is the shockwave to dissect that aortic plaque and create a dissection. So what are your thoughts?
If you take a little, oh, I see. That's not really going to help us.
Yeah, that's my point. I tried pulling it down. It didn't help. So it's a tortuosity. I think we just go up very gentle.
Yeah, we'll just go gentle.
Yeah, go slowly.
Yeah, that was one of my questions, Ajit, is how we are doing the aorto subclavian ostium. So, you get a feel where sometimes there's an extension of the dissection into the aortic arch.
Okay, shock.
How do we manage that, or how do we treat that, I guess, is a question. So.
If it goes past ostium, you mean?
Yeah, exactly. Past the ostium into the arch itself. You know how sometimes we balloon dilate, there's a little bit of extension into the arch part.
Yeah. I mean, you have to be ready to kind of extend, have TVAR stent ready to go if it extends past it.
Can go up again.
But this, I think, you know, the most,
Yes.
it kind of ends right at the ostium. You know, the
Correct.
plaque goes past it, but there's no, like, you know, bulging of that plaque into the
It's
aorta.
shocking.
So I don't
Wow.
think you have to do that. But I think the balloon,
Look at the curve
it's
of
getting
the
better.
balloon. I mean,
Yeah,
that
and there's
again
some
gives you
luminal
the,
expansion.
yeah, that also
Wow.
gives you an idea of how much tortuous and complex that arch is.
I wouldn't go more than 4.
Yeah.
Again, we have our crack nursing team here. Reese and Denise are telling me pressure is this, pressure is that in my ear. So obviously everything is going well. Ray's kicking me under the table. So I think everything is going well when Ray does that.
Yeah, that's a good sign.
That's
That's
a
a
good
good prognostic sign.
All right. So okay, now we're gonna have to switch out for an 035 wire to get the VBX across. So we need to switch out again, do all that magic again one more time.
No, let's just do a 4. I mean, I would use a lot of the shocks in this case, really.
Well, I'm gonna do all the shots.
Yeah.
Yeah, we're gonna do all the shots.
Well, we're getting the VBX ready.
Yeah, we'll get the VBX ready. Get us
So-
to 7-0.
We probably need a really short one, right?
7-0. Mike, 7-0 what? 17, 18? What do you got for me? 19 is fine. 29 is good too. Because it's a 40 balloon.
I don't know.
Well,
we have to
the
take a good
vert-
picture of the Lima and the word.
So when
very
I was
common.
looking on the CAT scan, it looked like it was around 20
Okay,
to
she's
25.
moving. Is she okay?
So I think we might need a 19 stent.
Careful.
That'd be my guess, but
I think she opened, no? Want to do one more?
one
Yeah.
more
Go
just
one
for
more.
a good measure.
Last ACT is 212.
Good.
The pressure
think-
looks beautiful. The heart rate is fine. The balloon expansion is good. So I think we're in a good zone right now.
So we're technically across the vert right now. Shocking.
Yeah.
Pressure.
Fine.
Okay.
Okay, down. I think that's good.
Yep.
All right, let's go ahead and I'm just going to track this up as you pull the shockwave back.
Okay,
Can you
starting to
push
pull
the
back.
balloon up a little bit? Would it go beyond PK? Yeah. That's it.
Okay.
Perfect. Yeah. Nice.
Yeah. Okay, let's take a picture, guys, here as the balloon comes out. Once the balloon comes out.
One corner.
Yeah, for now. And I'm just going to bleed back because I know you may suck back a little bit. Hold on.
Okay. Yep.
Bleeding back. Okay, ready to inject? Not wow yet.
Nice.
Okay, so let's go ahead. Now you have reversal of flow and the vert is now gone, right? So you got to be careful
Yeah.
now. And now is when you can embolize. So let's go to an areocranial view here.
So there's a question from the audience for Ajit and PK. Once you cross the lesion, is there any role of doing filters like how we do in carotid, especially with the dominant?
Absolutely zero role of doing filters in any sort of inject.
Yeah, there's also no room to put it a filter.
There you go. This is the best view, guys. You see the
Yeah.
view here? So this is the view where you really want to at least get to the distal vert. So you got the vert of the lima, it's the areocranial view. So now you want to see whether your stent will track. Also, I want you to notice the eccentricity of our lesion. You notice the most of the calcium is the other way. The other view you can go to is the LAO caudal view. This is what, you know.
The ostium. Yeah.
So the ostium, but more importantly, I do it for multiple reasons. One is to look at this, and also to look at, you see the calcium? So that's why Ajit and I decided we will take a little bit of luminal gain. We don't need a lot of luminal gain here. So we're going to undersize this, go with a 7019, and probably try to land it a little short. 19 should be enough, Ajit, no?
Yeah, I think
20 something.
I would say 19 should be enough.
20.
We
Let's
can-
try to
yeah.
track it. If not, we'll switch.
I think 29 is going to be too long.
All right,
And then
19.
we need, should we switch out for 035 wire?
100%. Give me the catheter, guys.
Opening 7 by 19.
And do you think the sheath will track through this lesion with a dilator and 035 wire, so that way we don't have to...
I mean, I'm afraid of
Push it.
pushing plaque into the
Yeah,
vert.
that's a good point.
That's my worry.
I guess we'll try it once,
I mean,
just
I
with the
think
sheath.
it'll go. I
Yeah.
think the VBX is I don't want to say this because of Gore's undying support to us. VBX is
It's okay,
a
Mike's not listening.
very trackable coverage stent.
You hear that, Mike? Trackable.
By the way, to everybody at Gore, Michael is there promising to meet me in the parking lot if I say anything different. So here we go. Okay, ready? There we go. So I'm just going to go, Ray, fix the sheet, brother, please. So let's go in and hopefully this will also give us an idea of how it tracks. You saw when Dr. Rao pushed it last time, there's no real resistance.
That's pretty good.
So I'm just going to take this as far down as it goes and then look at my arm and then decide.
Supercore or what wire?
I would do
Supercore is ready.
Yeah, Supercore is right there.
Okay.
Okay, beautiful.
Okay.
Supercore wire,
Yep.
guys. What happened to my pressure, guys? Cycle a cuff? Huh? No, it's a 7 though.
Your blood pressure is good. Yeah.
Yeah, but what happened to my waveform?
Yeah.
Are we in the lesion up here?
No?
Yeah, we crossed the lesion.
With
no, it's the
no,
catheter.
yeah, it's the catheter.
No, catheter.
All right. Well,
Yeah, what happened to the waveforms? Yeah.
check my waveforms.
And we'll have to zero. I'll zero my phone.
Wow.
Wow.
Pretty violent, man.
Yeah.
Okay, well.
Is that going to poke through the valve, you think?
Let's try.
You really want to externalize it?
No,
It's a
did not
soft
poke.
end.
Did not poke.
That's
okay.
fine.
That's fine.
That's okay.
Fix the sheet. Okay.
What was the last ACT?
Where's my pressure?
I'm zeroing the line.
Yep. Got wire.
No sheet's in the lesion. That's why.
Right. Okay.
Okay.
We'll take the VBX.
Zero, please. Pressure.
But I think
Nice.
kind of that's an important
Yeah.
point. You don't want to dislodge the balloon expandable stents.
Correct.
So ideally, you would get a sheet through it and then unsheath the stent.
Yeah. I agree.
If
That's
you
the
have
normal
that
treat.
option, but in this case, you could embolize. So try without it.
Yeah, I think in this case with the wire support and your balloon dilatation with shock wave, hopefully it should transcend through the lesions with relative ease.
I think
And
we're
like
there.
PK said,
Very short,
Good.
man. Ready? Let's take a picture.
Let's see where that vert is.
Ready?
yeah,
for
I think
picture?
you have to look at the lima and the word.
No, we're not going to cover it with this. That's what I'm a little concerned. Hold on. Don't attach. We may remove it.
It'd be nice to have a catheter from the other end, then.
Inject. See, we're not even there.
Well, it needs to go in more too, don't you think?
Okay, we can go in a little more.
If it will go.
It'll go.
Yeah, right there. Pushing there.
So, yeah, the LAO will tell us where we are with the origin,
Yeah.
and then the RAO will tell us for the vert.
And the lima, yeah, both.
So I think,
Yeah, once you push, I'll push the catheter with it.
what do you want me to do?
Push the stent.
Okay,
I'll push the catheter.
pushing.
Nope.
Nope.
All right, get us a dilator. We're going to have to do it. Walk it out.
But do you want to just double check
Let's
that?
take a picture now.
Because then 29,
take a
another,
Take a picture.
yeah.
See, that's the ostium. See, you're not
So-
long enough. See, you're not going to cover that proximal dissection, you'll see.
Yeah.
See this here? Take another picture.
Where's the vert?
So distally, you're fine.
Because the next option is adding a centimeter, and the problem is,
I think it's fine. You leave that little thing, don't you agree?
I think so. Because we can always
I
do
agree.
another short 19.
I agree. We're good
Because
here.
29 is going to be too long.
Let's go here.
It's going to be way into the
Yeah,
aorta.
that's what I was
I
saying.
think we're good to go up.
Ideally, we get like a 25, but it's.
I think we're good to
Yeah.
go up. You
I
agree?
think, yeah, I would.
Okay.
I think so.
Ready, guys?
Do we have another 19 available? Okay.
Yeah, you could do an overlap and then do your exact measurements. But yeah, 29 will be too long. You're going to definitely
then-
extend beyond it.
And
And
what's
then you have to
now?
overhang the
Yeah.
stent into the aorta, which hope you
Yeah,
don't
we're
want to
good.
do.
You
I
can
like
see the
that.
vert? Okay.
You want to come back a little?
I just can't see the vert too well.
No, Bert, the other view we had.
Yeah, I think the caudal view is good for you.
Because I'd rather extend towards the ostium. I'd rather get the vert.
So
with
he
the
wants to
tongue.
do distal to proximal.
Oh,
He doesn't
yeah.
want to cross the other stent through the first
Ready?
freshly deployed stent, which I think
Right.
makes better sense.
Yeah, I think
We're
we're.
perfect.
Yeah,
No?
I think that looks good.
I don't think
Yeah,
you're
but-
gonna need. I don't think you're gonna need another stent.
I don't think so.
Yep.
Really?
All right. Well, let's go up.
We are going up.
I
Yeah.
mean,
What's nominal?
8.
Yeah, okay.
We're going up, right?
Mm-hmm.
Yeah. Yeah, I definitely want to go past 8. Just no, yeah, 8's fine.
Okay, down.
Yeah, 8 gives you nominal of a 7.0, so you can go even higher up to get to that 8.0 size. But I
Now
think
the
it should be
balloon.
okay.
Ooh, is it? Wait, hold on. I wouldn't go up.
Sometimes
now.
you gotta.
Walk it back now a little bit, slightly.
Sometimes it gets a little stuck, and you gotta swallow the
Yeah.
balloon a little bit.
Yeah.
But this one came
Now
out.
go up here. Go up here.
Okay.
Go up here. Yep. Hold on. Let me
Oh,
go
on
up.
the sheet. Yep.
Go up here.
Uh-huh.
Going up. 2, 4, 6, 8. Down. Now I'm going to track the sheet across the balloon.
Mm.
Yep, I'm giving you a rail.
Uh-huh. Okay, good.
Nice.
All right, walk it back. All
So
right.
that was a good trick too, swallowing the balloon so you can re-engage the vessel.
Yeah.
Okay, DSA guys here.
Okay.
DSA.
And then we'll leave the balloon on the wire.
Yep, always leave the balloon on the wire. Don't detach the your stuff. Inject.
I think we're
I
good.
think proximally it looks fine.
I'm just worried. And distally also looks fine.
Distally, I think looks okay. Another picture would
I'm
be
gonna
good.
okay, ma'am, I want you to take a deep breath in and just don't breathe for me. Okay? Breathe normal, breathe normal, breathe normal. All right, deep breath in. Let it all the way out. And now don't breathe. See that dissection, that's what I'm worried about. You breathe normal. You see, I think it's a retrograde dissection. I think you should be okay, right?
The problem is it's very close to the vertebral.
I know.
We can maybe take one more view to really see it, but I think if
Just leave it.
Yeah.
probably just leave it.
I would just leave it.
I would leave
The
this.
stenosis is gone.
Mm-hmm.
The flow is good.
Flow's good.
Antegrade, both
Breathe
into
normal,
the
my
lemur and
love.
vertebral.
Breathe
Yeah, I think it
normally.
looks good. I mean, probably just.
Let's go ahead and do a, it's the go coronary here, guys.
Corner.
So it's the same thing when we did the renal case with Dr. Caraccio. Remember, we left the dissection and
Yeah.
the patient is done fine. The blood pressure is actually very well controlled. So you can see here there's no flow limitation. The stent is beautiful. There's a little aortic crud there. But again,
Yeah.
that's probably because of our injection into the plaque.
And it refluxes into the aorta nicely, which
So,
means there's...
Yeah,
you
so
know.
I don't think there's any issues here.
Yeah, I think we
I
treated
think
the
we stopped,
stenosis.
man.
I agree.
I mean,
I
what do
think
you
we're
think,
good.
Vishal?
No, I agree with you. I think it's the stent sizing was good. I'm not going to touch that distal. And like you talked about, getting the gradient off, and with good flow, there is antegrade flow now both into the lemur and the vertebral. I would not do anything.
Well, let's just show the flow in the stent here. See, the stent fully fills.
Yes.
And over here also, this one may be not a good picture.
But the
But
distal
still,
of
you
the
can see
stent
the
looks
stent
good.
is really filled,
Yeah.
So, I
We
mean,
could do an aortic run just to be sure.
I think the stent is well opposed, and there's
We
no
could do an
distal
aortogram to
dissection. Right
finish.
You
there.
can do it offline, yeah.
yeah, we'll just do so everybody at home, we're going to do an aortogram offline to look at the characteristic of the aortic plaque. I'm going to do a gradient across this. Let's give me a no, I just need a pullback gradient. Give me a straight aqua tempo. I just want to do a pullback gradient into the stent. I'm going to do a simultaneous distal to proximal so I don't lose my wire position. So if I reduce my gradient, I've got antegrade flow in my vertebral. I think we've achieved all the goals that we wanted in this particular case. Again, as for all the cardiologists at home, it's very important to remember it's not like a coronary. It's not vessel, but the vessel has to look gorgeous. Obviously, this situation here is again a gradient issue, and we've done a great job with the gradient.
Yeah.
So
Yeah, the enemy of good is better
exactly,
in this case.
in this case for sure. So we're just going to go ahead and put this across. And again, I want people to think about all the discussion that took place. I know we succeeded, but we were very okay with stopping. We were more than okay with saying, hey, you know what? It's okay. We did a good job. We couldn't get through. Wire out now. We couldn't get through. And now I'm going to do a simultaneous gradient here and there. And then we're going to zero both. Can I have the second transducer, please? So always in these kind of cases, guys, have two transducers, with your team. So make sure you don't have air guys here. And then we're going to do a simultaneous gradient. And if we've abolished the gradient or even reduced it significantly, I think we're done. So we're just going to show the physiology of what we want to do. So
I think that's a great demonstration of how tactically to approach patients' complex cases like this, and like you rightly said,
Zero both guys.
to bail out or to stop when you have to, in order for patient safety.
And it's also a good way to look at it like a team-based approach. You know,
Right.
you've got a vascular surgeon here who knows obviously, and look at the gradient. So we're absolutely done.
Nice.
So we're absolutely done. Yes, and the other thing also I want everybody to go over, because before we sign off, I know we're 15 minutes over, is you got a dissection, but this is a 9 to 10 millimeter vessel. You know what I mean? And I don't want you to get crazy about this small little dissection. That thing is going to heal up. I mean, what do you think, Ajit? It's not flow limiting, you know?
Yeah.
I mean,
Yeah, no, I agree. It's very focal.
you could put a short bare metal if you'd like, but then
No.
you're really considering
No.
taking that vert.
Yeah,
I doubt that dissection is going to. We could IVUS.
You
want
could-
IVUS?
not really, but
No,
I think it
don't
looks
want to
really
have
good.
us-
There's no pressure gradient, and it's a very focal dissection, so definitely leave it alone.
Yeah.
You know, in this area, with that how it looks, it's going to be fine.
Yeah, I think we don't want to be like overachievers in this, because I think it's a beautiful result with great stent expansion, good antegrade flow, very nice vertebral, very nice lima. I think we just should leave it. And you've hemodynamically also proven that there is no gradient. So I think
Get ready to
all the
inject it.
markers are towards saying it's the end of the case.
So I'm just going to pull back here just to see whether we lose the vessel or not, because sometimes the dissection flap can close. Inject. So you can see there's
Really?
again good flow. The dissection flap didn't close. And that's a question I know the audience would have, like, hey, Prakash, did the dissection flap close? It obviously didn't. So I think we got the proximal edge of the dissection. We're all done. So Ajit, thank you again, brother. Thank you for all
pleasure.
your time and your help. David, great case. Huh? Yeah, and I forgot to mention our lead tech, Kenley, who was forgotten. Where is Kenley? Kenley, I'm sorry I forgot to mention your name. Thank you for all your help. So anyway, thanks, Ray. So to sign off, my friend, and we'll talk to everybody next month.
Awesome. All right. Thank you so much,
Thanks,
everyone,
guys.
for joining us for this very interesting, fantastic case of brachiocephalic subclavian intervention here from Mount Sinai Hospital. Before we sign off, just to let you know about your New York Endovascular Summit, which this year is from September 12th to the 13th as the main session, preceded by a fellows day at September 11th. We highly encourage fellows for a great fellow session to register for our course right here, which has all world-renowned faculties, including our own Mount Sinai faculties here for the teaching purpose right there. It's almost full, but we still have a few more spots left for the fellows registration. In regards to our annual summit, which is on September 12th and 13th, as you can see the agenda online on nbyebs.org, we have world-renowned faculty coming from Europe, Japan, from North America here itself, across, to have a nice interactive discussion, have some fun. We have great live cases, data discussion, as well as emerging technologies. So we hope that you can join us at the New York Endovascular Summit here in New York. Places at Marriott Marquis, right in Times Square, the heart of the US and of the world. So register online at nbyebs.org. And as for the live case, we'll see you next month, July 23rd, 8 o'clock Eastern Standard Time, here from Mount Sinai. Till then, have a great day, week, and a month.